Digoxin belongs to a group of chemicals known as cardiac glycosides, which contain a sugar molecule, or glycone, bound to an aglycone, in this case a steroid molecule. Digoxin is often confused with digitalis, which is a mixture of compounds extracted from the dried leaves of the foxglove plant, commonly seen growing in hedgerows and along roadsides. Digoxin is only one of the cardiac glycosides found in digitalis, but it is the main one. Although digoxin can be synthesized in the lab now, it is still prepared for clinical use by purifying it from extracts of foxglove plants. Digoxin is used to treat heart conditions, primarily the cardiac arrhythmias, atrial fibrillation and atrial flutter, and heart failure. It has two actions that are responsible for its therapeutic effects. It increases the force of contraction of the heart muscle, and it slows the rate of electrical conduction through the atrioventricular node in the heart. This diagram represents the alpha and beta subunits of the sodium-potassium ATPase, or sodium pump, which pumps potassium ions into cells in exchange for moving sodium ions out. We've known since about the 1950s that cardiac glycosides block the activity of this enzyme. We now know they bind to a site in the alpha subunit, located on the extracellular side of the protein, and their binding prevents potassium ions from binding to the protein. This blocks the activity of the pump. We also know that cardiac glycosides cause a rise in the cytoplasmic calcium ion concentration in cardiac muscle fibers, which amplifies electrically evoked contraction. This was discovered by measuring the tension developed by a muscle fiber at the same time as recording the concentration of calcium ions inside the cell using a calcium-sensitive indicator. This figure shows that in control conditions, electrically stimulating the muscle fiber at the time indicated by the arrowhead caused the muscle to contract following a small rise in calcium concentration. When digoxin is added, the contraction and the rise in calcium are larger. Importantly, the rise in calcium precedes the rise in tension because it causes the muscle contraction. The next question to ask is, how does blocking the sodium pump cause the larger calcium transient when the cell is stimulated? To answer that, you need to know how cardiac muscle cells normally contract when stimulated by an action potential arriving from the sinoatrial node. This diagram illustrates part of a cardiac muscle cell, which is surrounded by the plasma membrane at the top. The membrane contains the sodium-potassium ATPase. It also contains a sodium-calcium exchanger, which removes calcium from the cell after contraction in exchange for transporting sodium ions in. The sarcoplasmic reticulum in the cell acts as a store for calcium ions and is an important source of calcium ions for contraction. Its membrane contains a calcium pump called SERCA, or the sarcoendoplasmic reticulum calcium ATPase, which pumps calcium ions into the sarcoplasmic reticulum from the cytoplasm. It also contains a calcium permeable channel called the ryanodine receptor, which opens to release calcium from the store into the cytoplasm. At regular intervals, the membrane of cardiac muscle cells dips into the middle of the cell to form T-tubules. This architecture is important for contraction because it brings voltage-dependent calcium channels in the T-tubule membrane close to ryanodine receptors, so that calcium entering through the calcium channels immediately encounters ryanodine receptors, where it binds to open the ryanodine receptor channel and releases calcium from the stores into the cytoplasm. It is this burst of calcium that evokes contraction. So let's see what happens when we block the sodium pump with digoxin. Normally, the pump moves sodium out of the cell to create the sodium gradient. The sodium gradient is used by the sodium-calcium exchanger to remove calcium from the cell. When digoxin blocks the sodium pump, sodium is no longer removed from the cell in exchange for potassium, and the sodium concentration inside the cell remains high. That depletes the driving force for the sodium-calcium exchanger, thereby inhibiting the removal of calcium from the cell. The concentration of calcium ions in the cytosol therefore starts to increase. However, SERCA is able to remove the excess calcium rapidly into the sarcoplasmic reticulum, filling the calcium stores. When the cell is excited and calcium channels open, calcium enters as normal, opens ryanodine receptors and evokes calcium release. But as the stores contain more calcium than usual, the amount of calcium released is enhanced, causing greater tension to be generated. That is the situation at a therapeutic level of digoxin. If the pump is inhibited more, the calcium stores become overfull as SERCA continues to accumulate calcium. The level of calcium can reach a point that forces the ryanodine receptors to open spontaneously, and calcium bursts out. Calcium can be released in high amounts next to the membrane, enough to trigger the sodium-calcium exchange to remove the excess calcium, despite the low sodium gradient. This causes the toxic effects of cardiac glycosides. In a healthy heart, between the action potentials in ventricular muscle, the membrane potential sits silently at the resting potential. In contrast, when digoxin is present at toxic levels, the membrane potential between action potentials shows irregular bursts of depolarisation. These are known as delayed after depolarisations and are often referred to as DADs. Action potentials that originate in the sinoatrial node appear at regular intervals, as indicated by the blue arrows. Notice the extra action potential. It is called an ectopic or extra because it originates in the ventricular muscle itself, not in the sinoatrial node. Most of the DADs depolarise the cell a little, but not enough to trigger an action potential. However, occasionally a DAD is large enough to depolarise the ventricular membrane to threshold and evoke an ectopic action potential. So, can we link the DADs to the bursts of calcium that are released from the sarcoplasmic reticulum and activate sodium-calcium exchange? The answer is yes. Remember that the exchanger moves 3 sodium ions into the cell for every calcium ion it removes, so there is a net movement of positive charge into the cell. In other words, the exchanger generates depolarising current. So, DADs are caused by sodium-calcium exchange current activated by calcium released from overloaded stores. The varying amplitudes of DADs reflect varying amounts of calcium reaching the membrane during a burst of calcium from the sarcoplasmic reticulum. Ectopic action potentials generate ectopic ventricular beats. This type of arrhythmia is seen at toxic doses of cardiac glycoside. Because of these effects, digoxin has a low therapeutic window or index. That means there is a narrow range of doses over which it is effective without causing unacceptable side effects. The therapeutic index of a drug is a number calculated from a ratio where the minimum dose causing unacceptable adverse events is divided by the minimum dose causing a therapeutic effect. For digoxin, toxic effects are seen just above a serum concentration of 2 nanograms per ml, while it is effective at serum concentrations between 0.8 and 2 nanograms per ml, although these values vary among patients. The narrow window means that patients needing to take digoxin are closely monitored. You now know how digoxin stimulates the heart to contract more forcefully, but it does not explain how digoxin slows electrical conduction through the atrioventricular node. That is caused by actions on the parasympathetic nervous system. Parasympathetic neurons run in the vagus nerve from the brainstem to cardiac ganglia around the heart. From there, they innervate the sinoatrial node. At the synapses, the transmitter acetylcholine is released onto the pacemaker cells, which contain muscarinic acetylcholine receptors. Binding of acetylcholine to the muscarinic receptors slows the rate of spontaneous action potential firing, which slows the rate of the heartbeat. The atrioventricular node is also innervated by parasympathetic neurons, which release acetylcholine onto muscarinic receptors. Activating the muscarinic receptor there reduces the rate at which electrical signals are conducted through the atrioventricular node. The same mechanisms are responsible for the effects of parasympathetic stimulation on the sinoatrial and atrioventricular nodes. Action potentials recorded from cells of the sinoatrial or atrioventricular node look like this. The cell membrane gradually depolarizes until it reaches a threshold level, when it rises rapidly to a peak, then recovers to start the process again. When the vagus nerve is stimulated, the membrane potential at the end of each action potential reaches a more negative value, so it takes longer for the subsequent depolarization to reach threshold. This extends the time between action potentials. This occurs because muscarinic receptor stimulation opens a potassium channel in the cell membrane, which mediates potassium ion efflux from the cell and hyperpolarizes the membrane. So how is this relevant to digoxin? Digoxin stimulates the activity of the vagus nerve, potentiating all of these effects of acetylcholine. It acts at multiple levels. It increases the activity leaving the brainstem, it stimulates the cardiac ganglia, and it stimulates the nerve endings that innervate the two nodes. I could not find much in the literature about how digoxin does this, but blocking the sodium pump would depolarize the neuronal cell membrane, making it more excitable. Also, at nerve endings, depolarization activates voltage-dependent calcium channels, which would increase calcium influx and neurotransmitter release, in this case acetylcholine. If you remember from earlier, digoxin binds to the alpha subunit of the sodium pump, but there are multiple genes encoding different isoforms of each subunit. There are 4 alpha subunits named alpha 1 through to alpha 4 and 3 beta subunits, beta 1 to beta 3. There are also splice variants and tissue-specific post-translational modifications that increase the diversity of the pump proteins. These can all affect the properties of the pump and its sensitivity to drugs. The alpha 1 subunit is found in tissues throughout the body, and alpha 1 beta 1 is a ubiquitously expressed complex. The alpha 2 subunit is predominantly expressed in muscle, including cardiac muscle. The alpha-3 subunit is mainly expressed in neurons, while alpha-4 is restricted to the testes. But tissues generally express multiple isoforms of the pump. Digoxin can bind to all alpha subunits, but it shows some selectivity for alpha-2 and alpha-3 in comparison to alpha-1. It is 4 times more potent at inhibiting sodium pump activity when the pump contains the alpha-2 subunit, and twice as potent when it contains alpha-3. This helps to explain why the main effects of digoxin are on the heart and vagus nerve. In muscle cells of the heart, the alpha-1 beta-1 isoform is distributed evenly throughout the membrane of the cell. In contrast, the digoxin-sensitive alpha-2 subunit assembles preferentially with the beta-2 subunit, and the complex is localized in the membrane of the T-tubules. It is also located close to the sodium-calcium exchanger, explaining how the two proteins are able to functionally interact. This means that digoxin can disrupt the calcium transport role of the pump in the T-tubule while having minimal effect on its other roles in the cell. Since alpha-3 is a neuronal subunit, you may be wondering why digoxin increases parasympathetic nerve activity, but not sympathetic nerve activity. It is most likely because digoxin stimulates nerve activity from baroreceptors in the vascular system. In that way, it mimics the body's reflex response to a rise in blood pressure to counteract the rise. Increased baroreceptor signals arriving in the brain lead to increased activity in the parasympathetic nerves and decreased activity in the sympathetic nerves leaving the brainstem. To sum up, I've shown you how digoxin affects the heart. This cartoon illustrates an atrial tachyarrhythmia where the atria are beating rapidly and largely independently of the ventricles. As a result, the ventricles are not adequately filled between beats, impairing the stroke volume and cardiac output. When digoxin is administered, the heart slows down and the ventricles beat more slowly and more robustly. 3 actions contribute to digoxin's effects: slowing of the heart rate at the sinoatrial node, slowed conduction through the atrioventricular node, and increased force of ventricular contraction. These actions together mean that the frequency of excitation of the ventricles is reduced, but the signals that do get through cause greater contraction. That in turn improves the stroke volume.